Hello and welcome. My name is Dr. Jack West, and I'm a medical oncologist and the founder and CEO of GRACE, the global resource for advancing cancer education. This is part of a series of podcasts covering challenging clinical cases in lung cancer that don't have a clear, correct answer for the best treatment based on the evidence, and they therefore require our best judgment as experts consider the options and the merits of one treatment over another. The same series of cases was discussed with multiple experts in the field of lung cancer from several different institutions to provide a better sense of where there is consensus and where there is still a wide range of treatment styles that might all be considered appropriate. Each podcast starts with a brief thumbnail of a case presentation and then discussion from a live program done with Dr. Robert Doble, Assistant Professor of Medical Oncology at the University of Colorado Medical Center in Denver, Colorado, and Dr. Jyoti Patel, Associate Professor of Medical Oncology at the Feinberg School of Medicine at Northwestern University in Chicago, Illinois. The discussions will then continue with commentary by several other clinical experts, including Dr. Suresh Ramalingam from the Winship Cancer Center, Emory University in Atlanta, Georgia, Dr. Jonathan Goldman from Premier Oncology in Santa Monica, California, Dr. Julie Bramer from Sidney Kimmel Cancer Center at Johns Hopkins University in Baltimore, Maryland, Dr. Heather Wakely from Stanford University Cancer Center in Palo Alto, California, and Dr. Karen Reckamp from the City of Hope Cancer Center in Duarte, California.
Moving on, we'll turn to unresectable disease. This is a 59-year-old woman with an excellent performance status, and she has unresectable stage 3B non-small cell lung cancer, poorly differentiated with some features of adenocarcinoma. And she starts on a course of cisplatin and etoposide for 2 cycles, along with radiation therapy to a definitive dose of 64 gray. And at the end of that, she's really tolerated it well, and she undergoes a repeat CT scan that shows a partial response, but some residual findings that are ambiguous, as is often the case. And it's not clear whether this is responding disease that may be dying and non-viable scar tissue, or whether there is viable cancer within that. Her performance status is good, and she's interested in chemo or some other systemic therapy at this point, but really open-minded to the question. And so I'd turn to you, Jyoti, about whether you would recommend any consolidation therapy, any further treatment after she's completed a couple of cycles of good systemic therapy with concurrent radiation.
This is such a common scenario, and it's so difficult because we generally, or I at least generally do a CT scan about 4 weeks after patients finish chemotherapy and radiation. I sort of set that CT up with telling patients that this is not to assess response because we know we'll continue to see response at 3 and 4 months out, but this is really to look for toxicity. We get that CT scan, and often the nodes are smaller, but they certainly haven't gone away, and they're difficult to interpret. I especially don't know what to do if someone brings a PET scan to me from another institution or another oncologist, because that will even cloud the picture more. I mean, are we seeing necrosis or are we seeing recurrent tumor? I don't know. If patients are feeling well and they've done quite well with chemoradiation, my bias has been to continue with consolidation therapy, so I generally give an additional 2 cycles of cisplatin etoposide. Several years ago, I would give docetaxel, but we have good data from Nasser Hanna and friends at Hoosier Oncology Group that doesn't improve survival and patients get into toxicity. I'm not sure if that's because of some of the pneumonitis issues. Certainly, we saw a lot more neutropenia in those patients. I tend to do more cisplatin and etoposide again, and I'll just do 2 more cycles. By the time you're done with that, patients have gotten a hefty dose of cisplatin, 400 milligrams total, and by that time they're generally willing to stop. I have not changed therapy very often, so if patients are getting cis-etoposide before, we know the JMIG trial, which is the phase 3 trial looking at cisplatin and pemetrexed, followed by more pemetrexed versus cisplatin etoposide. In that trial, the FDA actually mandated different regimens, so cisplatin, vinorelbine, or carboplatin Taxol. I haven't done that as much, but I think that would be reasonable as well.
Bob, what are your thoughts here?
Yeah, I would echo what Jyoti is saying, and that, first of all, I try to educate the patients from the beginning that the scans that we do after therapy are not going to inform us on whether we've gotten a long-term control of the disease. It can tell us whether it's failed, but it rarely tells us whether we've succeeded. Only time will tell us that, and that's something that's difficult. I think if you tell patients up front, it helps ease the anxiety later. I would agree that I also only do CT scans early and reserve PET CTs to evaluate findings that may be related to bone or other distant recurrence, because PET CTs are very difficult and can be misleading in both directions, with both false positive and false negative changes in the PET activity after chemoradiation. So I try to avoid that unless I'm looking for something outside the radiation field. The HOG data has given me pause in consolidation chemo, also along with the CALGB, where there was not a significantly different outcome in patients who received additional rounds of a different chemotherapy granted, so carboplatin paclitaxel. I'm not convinced that additional cycles of chemotherapy before or after are going to improve outcomes. So I would most often do 2 rounds of cisplatin etoposide with chemoradiation. I'm open to doing more cycles, but I'm not sure that the evidence supports necessarily a better outcome.
It's an uneasy time, I think, for all of us, because we don't have evidence of more being better, but it's hard to sit tight with just 2 cycles in, knowing that the risk of recurrence is very significant, but we just don't have evidence to show that we can make that better by giving more, and we have the potential to make things worse by adding toxicity more than efficacy, yet we're still left largely using judgment, I think.
One thing to bring up with this case, though, is this is a patient with an adenocarcinoma. One of her greatest risks of recurrence is in her brain, and so I think a few years ago there was a feeling that maybe these patients should get prophylactic cranial irradiation. There's been a study that's presented that was negative, but it was under-accrued. My feeling is that the patient should not get PCI in this situation, but I don't think it's a completely closed question.
Dr. Suresh Ramalingam from the Winship Cancer Center, Emory University in Atlanta, Georgia.
I think the SWOG study that looked at consolidation docetaxel clearly showed that giving 3 cycles of docetaxel in the post-chemo RT setting did not lead to a favorable outcome. That has really changed my view of how I approach consolidation therapy. For patients who get initial treatment with cis-etoposide and radiation, that alone remains the standard of care. There is no clear proof that giving 2 more cycles of either same cis-etoposide or any other chemotherapy or a targeted therapy actually results in improved survival. For this particular patient, with the regimen she got, I think this is adequate therapy. She is still at high likelihood of having recurrent disease, but there is no evidence that doing something more is going to alter that. If a patient receives the carboplatin paclitaxel chemosensitizing regimen with radiation, those patients, I'm inclined to give them 2 cycles of systemic doses of carboplatin paclitaxel in the consolidation setting, as was done in the major studies with this particular regimen. So that's my approach to stage 3B disease after completion of chemoradiation.
And I presume you're not especially inclined to pursue prophylactic cranial irradiation in this setting?
No, we do not routinely do prophylactic cranial irradiation. I am aware of the RTOG trial that was reported last year that suggested, even though the trial was closed for slow accrual, there were some trends that indicated benefit. But clearly this is an area where we don't have good evidence to give this to all patients.
Dr. Jonathan Goldman from Premier Oncology in Santa Monica, California.
As you know, there's no evidence that anything further would improve her outcome. But from lower risk disease, we think that at least 4 cycles of chemo is necessary. I guess probably the only thing that's clear is that docetaxel as a switch or Taxotere doesn't make a significant benefit. In the end, I usually give 2 more cycles of the same chemotherapy.
Even though we don't have evidence, it still doesn't sit well with most of us.
Right, because we know that the metastatic disease is a significant issue, micrometastatic disease more specifically, and we don't think we've given enough chemo for that.
Dr. Julie Bramer from the Sidney Kimmel Cancer Center at Johns Hopkins University in Baltimore, Maryland.
Good question. If there's a question of residual disease, I usually will consider consolidation chemotherapy, and I'll still stick with the cisplatin and then either combine that with Taxotere or even potentially Alimta or even gemcitabine, depending on the patient and what subtype of tumor that they have. If there's really no evidence of residual disease, I don't. So again, the most recent studies say cisplatin, etoposide, and radiation, you're done with the treatment, and you should do just as well as compared to with chemotherapy afterwards, but I think no one really has looked at the cisplatin regimens after the radiation with the cisplatin etoposide.
I think it's hard because it's not like we've achieved such phenomenal results that it's hard to rest on our laurels here, and I don't think anyone's really satisfied with that, and yet we don't have evidence for anything beyond it.
Right, and it's a long conversation that you have with the patient about the potential risks of the chemotherapy afterwards versus trying to get some type of benefit.
Do you think that the additional systemic therapy raises the risk of pneumonitis?
Yes, it does. A lot of the chemotherapy that we have can cause pneumonitis on its own, and then on top of radiation, it might increase that chance. We just don't have a whole lot of information about that. So that's why we pick the regimens pretty carefully.
Dr. Heather Wakely from Stanford University Cancer Center in Palo Alto, California.
I tend to give 1 or 2 more cycles of the cis etoposide. I'll change the regimen a little bit. I won't give the 50-50 of the cis. I'll switch over to 75 on day 1 and 3 days of etoposide.
Okay. Obviously, nobody has good data on this, but nobody's very happy stopping with 2 cycles.
Right. Oh, there's some, but I'm not one of them.
Dr. Karen Reckamp from the City of Hope Cancer Center in Duarte, California.
So generally, it depends on how she's feeling right now. But generally, for patients who can tolerate the full cisplatin etoposide, the SWOG dosing of cisplatin etoposide, I'm assuming that was weekly cisplatin for 2 weeks and 1 week of etoposide. So if it's full dose and they get the 2 cycles, I tend not to give any more therapy based on the questionable efficacy of adding docetaxel after. If I'm giving weekly carbotaxol, which would be the other regimen that I use more frequently, then I would tend to give a consolidation 2 courses or 3 courses of chemo following because they haven't received full doses of chemo. But if they get the full cisplatin etoposide, I tend not to unless they really had no toxicities, which is pretty rare.
Do you tend to favor the weekly carbopaclitaxel based on a sense that that's essentially equivalent outcome or just the feasibility of getting patients through this aggressive approach?
I favor cisplatin etoposide because, again, I think there is benefit to giving full dose chemo while you're giving radiation because I think you're attacking, again, micrometastatic disease and preventing metastatic disease from happening, but I think it's difficult to tolerate. So if a person has more comorbidities or poor performance status, I will tend to use the weekly carbotaxol or questionable renal function so that you can withhold a dose. And it's a little easier to give, but for curative intent, I still prefer to use cisplatin etoposide.
We hope that the program was helpful, and we'd again like to thank the folks from Longevity Foundation for their partnership on this program. Thank you.